Hi everyone, I'm Dr. Faisel Syed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care.
And today, we have some thrilling news for you.
That's right. Get ready to mark your calendars because we're bringing the conversation to you live and direct.
Join us at the highly anticipated Primary Care 24 event on Wednesday, May 22nd, where we'll be hosting a special live recording of our podcast.
It's going to be an absolute blast, filled with insightful discussions and special guests.
Whether you're a healthcare professional, a policy wonk, or just someone who cares about the future of primary care, this event is for you.
So grab your headphones, your favorite beverage, and head over to primarycareforamerica.org/primarycare24, or just click on the link in the show notes to register for the event.
Don't miss out on this unique opportunity to be part of the conversation shaping the future of healthcare. See you there.
Register now at primarycareforamerica.org/primarycare24. Faisel and I can't wait to see you there.
Today, we're talking to Dr. Mark Zhang from the American Medical Extended Reality Association about XR Unveiled, innovation on the edges of healthcare. Let's dive right in. Oh, Dr. Dan, it's good to see you.
Good seeing you, Faisel.
I feel like it's been like a month I haven't seen you. We can't do this couple days thing. This has been far too long.
That's right.
And Dr. Zhang, it's good to see you. Welcome.
Thanks for having me, Faisel. Nice to see you again, Dan. Great to see both of you.
Absolutely. Good seeing you and looking forward to this conversation.
Yeah. I knew from the moment I heard you speaking on that stage. So we met each other. We met at the Reimagining Primary Care Forum in Boston. And I knew from the moment you started speaking, I was like, we got to get him on. I mean, people are talking about all this amazing work with the intersection of medicine and technology, but that's like all talk. I mean, when you start speaking, I mean, it's like real tangible. It reminds me of like what the conversations in the early 80s. My dad's a retired inventor from AT&T Bell Labs. So they were talking about voice recognition and flash memory in the early. You sound like one of those guys who needs to be like in a think tank for the country. Where did this all come from?
Very, very kind. I'm an internist by training. So I did my training. I like to tell people, and this is partially the myth, but also mostly true. Most of the pathway that I did, like most people, was probably a lot of luck and just being in the right place at the right time and a little bit of interest and talent. But my background is I'm an internist by training. I did my training at Allegheny General Hospital in Pittsburgh, which is a wonderful place to train. Pittsburgh is a lovely, lovely area, safety net hospital. And, timing wise, right around the time I was a fourth year medical student, the iPhone was just kind of announced. And I've always been interested in technology. My gateway has been kind of video games and gadgets. And I remember kind of seeing my first iPhone. The sub-I at the time brought in iPhone 1. And I remember looking at it and thinking, holy heck, that's going to change how we practice medicine. So when I was an intern at Allegheny, I knew I wanted to do something in technology. I wanted to do something with these new kind of clearly disruptive technologies, these mobile computers in your pocket. I didn't know how, but at the time, as a intern with maybe a little less weight, a little bit more energy, and some thoughts of the world, I used my nights and weekends to kind of connect with universities across Pittsburgh. Found a couple CS groups that were willing to take me on as a kind of a business owner for this idea. I want to make a reference application for the residency, and then realized that was a viable pathway forward to build kind of applications. And actually, the work we do as physicians, particularly in primary care, internal medicine, and kind of our team-based interdisciplinary approach, actually translates beautifully into this field of informatics that I actually didn't even know was a clinical specialty until very much further in my career. So when I was an intern and internal medicine resident, I built apps for my residency and got pretty good at creating these kind of technologies through just animal charm and kind of convincing others to kind of see the vision and build this forward. I knew clinically I wanted to do palliative care, and I also knew that eventually I wanted to do something in technology and healthcare. And even though Pittsburgh is an incredible place to train, both for healthcare and also, frankly, for the CS, there's just incredibly strong CS. At the time, the infrastructure was still burgeoning. So I knew in order to really do it, I had to go somewhere where people had already done this work. There was a pathway forward. And I was very fortunate to do my palliative care fellowship in Boston at Mass General Hospital, Dana-Farber. During my nights and weekends again, got into kind of the innovation ecosystem, did the startup kind of pathway, created a venture-backed startup in the palliative care space. And actually, when I was a palliative fellow, I was known as the apps guy. I was the nerd of the fellowship. We were at the Brigham on consults, and my attending gave me a flyer that was advertising this new fellowship at Brigham and Women's, and it was the Clinical Informatics Fellowship. And I had no idea what informatics was. I just had no idea that was a field. So after I Googled it, I went, oh my gosh, this is exactly what I want to do. So I reached out to the director for that fellowship, asking if I could do a rotation as a palliative fellow. We got to talking. And he was like, you should just apply. So I did, and I was fortunate enough to be the first fellow in this CI fellowship. And that's where I kind of learned how to build these applications for organizations, and have kind of moved on forward from there in my successive roles.
Palliative care fastback, was that in Boston, or did you make that in Pittsburgh?
No, I built fastbacks in Pittsburgh. Actually, I built fastbacks in Pittsburgh through just, again, a lot of luck and just being in the right room at the right time. I was actually interviewing for palliative care fellowships, and I had an interview at Pitt with Bob Arnold, who's very well known in the field, and he's also on the editorial board for Fast Facts. And by then I had made a handful of applications for Allegheny General, and objectively, the Fast Facts website was maybe not as modern as it could be. So I was a little confident, and I was like, I could just build an app. And then 2 weeks later, I get an email from Bob, and he basically was like, bet, I'll put you up on that. That was enough, and we did it, and we built the Fast Facts app then. Just very fortunate, very lucky.
And I think this is great. When you talk about extended reality, I sort of go back to watching Star Trek when I was a kid. So this, I'm sure, was probably before you were born, because you thought about the communicators they had, where they would just sort of flip things out and they would have a video call in their hand. And I was sort of locked to landlines at the time. I think when I was a kid, we even had party lines, which was the old way. You picked up and you had to wait for the neighbors to hang up the phone. So I remember Dr. McCoy would have his sort of scanner where he would just run it up and down people, and then to figure out what was wrong with them, and would make things better. And when you were talking about it the other day, when you're talking about extended reality, is that what you're talking about? We put our Google glasses on and we don't need an ultrasound, or where do you think things are going to go?
No, Dan, it's a great question. Actually, that kind of fast forwards to kind of my current day. So, after CI fellowship, I've done kind of, various roles within Brigham and Women's and Mass General Brigham in the intersection of technology and healthcare and innovation, leading a group called the Digital Innovation Hub. And now in my current role as the Associate Chief Medical Information Officer, I focus on digital innovation for our organization. And one of those areas is really emerging technologies. So over the last couple of years, my team, we've had the pleasure of kind of taking a deep dive into just emerging technologies in healthcare and how we can support them. Does it make sense to support them? And how do we be sensible about kind of creating pathways and opportunities for the organization and also for our clinicians and staff to utilize these technologies in novel ways? So we started this work 2 years ago, and I promise I'm going to get to extended reality here. 2 years ago, when we were asked to kind of do this work in emerging technologies, we wanted to pick kind of an index case to actually figure out, well, what does that mean to really think about emerging technologies? And about 2 years ago, XR was very much having the generative AI kind of bump. There was just a lot of interest. The metaverse was going to be this $1 trillion kind of opportunity. Facebook had just changed its name to Meta. And it occurred to our team that no one on the team really had any idea what the ramifications for this would be for healthcare, if there were even any ramifications. So what we created was this kind of framework that we're using. Actually, we're using now for generative AI as well, which we call Next Up. And really, it's like kind of an opportunity and process that enables us to have a quick understanding of kind of an emerging technology, both in context of the industry as a whole, but also how it pertains to our organization, and then come up with an informed decision on how we best support this emerging technology. I'm a physician. It's a part of my identity. It's how I think about things, for better or for worse. So, of course, we based Next Up in our process on see, do, teach. The idea is we do a C phase, which is really our diligence phase, where we look at both the industry as a whole, but then what's happening within Mass General Brigham. And when we did that for extended reality, what was fascinating was we came in with no real biases. We just wanted to learn more. It was exciting to see that actually there was quite a bit of signal happening at MGB. Initially, when we did the first kind of internal scan, there were over 20 projects happening within our organization across like a lot of different sectors: surgery, mental health, infectious disease. And also what was pretty fascinating was that no one knew that anyone else was doing anything in XR inside of the organization. It's like fully siloed. When we looked across the industry as a whole, we saw the same. As we thought about how do we actually do work in this field, because clearly there was a signal there, it became apparent that building out that community and really breaking down those silos would be kind of the work to do. So that's what we've been doing over the last couple of years, is really creating that internal community for medical extended reality at MGB. And now really it's about teaching. So coming to things like this, talking with groups like the AMA and the American Psychiatric Association, talking with groups across kind of the spectrum, and talking about the opportunities in XR for medicine is kind of the next step, is really kind of expressing and kind of showing others kind of the opportunities. So, Dan, I think you asked initially, what are the opportunities for XR? You know, when I think of XR, certainly there's that vision of the holodeck in Star Trek, right? Like that's a Valhalla. That will eventually, some variation of that will eventually happen. I am confident, right? It's just a matter of time. That's the variable. And right now, when I think of XR or extended reality, really there's this, it's an umbrella term for technologies like virtual reality, which is more immersive. So you can kind of have an approximation of a holodeck if you wear a VR headset and just experience like a virtual world. You could essentially have a pretty rudimentary, even now, experience that kind of gets you sort of there. But then there are also technologies like augmented reality, which is really layering kind of digital onto our real world with context, ideally. So, you know, for surgery, people are using augmented reality for, again, another Valhalla use case I think about a lot and really excites me, because I think it's going to change quality of care and become the standard of care in the future. What if you could layer a CT scan of your own kind of CT scan onto your body in a one-to-one, fully accurate kind of way, so that as a proceduralist, you can see into a person's body like you have a superhuman power without any radiation, without any fluoroscopy. It's just persistently there. And then because you're using, you know, let's say a catheter, or you're a surgeon and you're putting in a screw, you know exactly the size and width and the length of the screw and the XYZ coordinates of how you're putting it in. Now you know exactly when to stop, right? As opposed to guessing, having to do a confirmatory kind of imaging in the middle of a procedure. All these things are possible. And what's exciting is we're not talking about a potential opportunity. There are companies today that are doing some of these things. And this is like the very beginning of this, what I think is a new field of medicine that will be powered by these technologies. Medical extended reality.
You know, I think about when GPS came out, right? I mean, when I finally decided to buy one of the old Garmin GPSs, is I actually had a presentation accepted at a meeting in Baltimore, and I was going to have to be driving through rush hour traffic in Baltimore by myself without somebody to read a map beside me. And I'm like, okay, well, I'm going to buy this. And, you know, it was sort of showing me a map and telling me exactly where to go and which exit to get off of. But that's sort of what you're talking about, right? You would be able to look and see, and not only that, it would almost be able to give you a cut here, put the screw here, and so you're looking at it, you put it in the right place, and it really helps guide you. I mean, you would still need the knowledge to make sure this is the right procedure to be doing and everything is still working together. But that's really what you're talking about, some things like that.
That's a clear end state of some of the work that's happening in augmented reality for surgical procedures, like that GPS, right? Whether it's that advanced level GPS where it's literally understanding the context of the procedure and then telling you the next step and showing you arrows and telling you to stop. Or maybe, right now I don't think we're fully there, but we're getting the pieces. The right pieces are in place where there's a tangible roadmap to get there. I think in the next, at least bare maximum, I guess, within the next decade, we're going to get to a place like that. Right now, I think where we're at is a place where we can at least understand and place kind of objects like organs or scans within context of a body, and then maybe give you real-time kind of visual details about where your kind of the tips of your instruments are or where the margins are for the thing that you're trying to kind of excise. The other thing I'll say is that this is just one use case for XR. The field of XR for medicine is broad, and it's not just surgical. So when we talk about VR and the abilities that are unlocked with virtual reality, certainly for exposure therapy, there's some of these like kind of low level, pretty like clear use cases that just make sense. So using exposure therapy for mental health professionals, it's a lot safer to be in a virtual car with someone who's scared of driving on the freeway than being in a real car with someone who's scared of driving on a freeway. So you can do that, and you can adjust the variables. You can kind of enable that type of intervention. And importantly, you can also do it remotely. So there's also social VR aspects. So, again, in the mental health field, there are a lot of really exciting emerging kind of players that are creating kind of group therapy opportunities using VR spaces. Have you ever had a meeting or done something in VR in a social kind of component, Faisel or Dan? Have you ever tried that?
Well, we not remotely with one person in one home and another person in the other. What we've done is we've done it where like my father's a big space person, and so his dream was to like, he loves these books on the space station and all that stuff, and I got him an Oculus and had him go into the space station, and we had it hooked up to our big TV, so everyone in the room was seeing what my father was seeing it going through, and that was quite pleasurable. And actually, the first thing he said after he had that experience was, number one, why it took me so long to get this device for him, but number two, he said, could you imagine what something like this would do for education? He just had a hip fracture just shortly before that, and he really didn't understand what was going on with the hip fracture. He wanted to understand. He was in so much pain and all, but he thought, boy, it would be amazing that you can go to you're at a hospital or you're at a clinic, you've got something that's going on, and they have you put this thing a much safer way of looking at the world. and when I'm hearing you speak, that's what I see. I mean, I just see
exactly. So there's so many opportunities where someone much smarter than me kind of described VR as an empathy machine. And I think there's this opportunity not only for education because it's immersive, you can't look away. And that's actually a lot of other sectors use it for on-the-job training through simulation. And we're beginning to see that for medical education, particularly in the surgical field. So procedures where, maybe at one end of the spectrum, you don't need super high fidelity. You're just kind of trying to remember the steps and understand kind of that process. But also on the other end of the spectrum, you can get to these very high fidelity with haptic feedback procedures where it's like Impossible Burgers, right? It's almost like you're eating the real thing, even though it's made from plants. And I think that's like really the opportunity. The other piece with social VR is that experience of being fully immersed. My team at the iHub, we have a meeting every week in VR. we're still a hybrid group. I'm currently in on-prem, but our team is distributed across Massachusetts and Boston. Once a week, we all don our VR headsets and we're in this virtual space. How I describe it is, it's cartoony, right? Like, it's not true to life. You look like a funny avatar. It's pretty good, but it's so much better than being in a digital window, like a Zoom window or one of these. It's not as good as being in person, but there's something to be said about being in a shared space where when you talk, everyone looks at you. It's directional. You're making hand gestures and people see that. You're looking at the same kind of virtual board. It's incredible. We've had these kind of meetings. We've been doing this for about a year and a half now. And what's wild is when the weather is particularly bad, or when one of us is like out of the country and we're able to still meet in this virtual space. And for 30 minutes to an hour once a week, we're all together in this space. And there's something really powerful about that. And I think that kind of application, those kind of opportunities, both for medical education, but also for things like group therapy and other kind of opportunities, virtual, how many telehealth visits could potentially be done using VR where there's a value add to being in that physical space? The question is, I don't know, but I think there's a really important opportunity there. And we're at the very beginning of this, what I would say is the beginning of a new medical specialty. And that's kind of what we're trying to do here.
How do you think the legacy players are going to deal with this? I mean, I wind up in conversations about trying to limit, the different specialties argue about the different procedures. Is we're not going to allow family doctors to do bedside ultrasound, even though a number of medical schools are teaching people to use ultrasound almost like they use stethoscope. We know that people who do a lot of procedures get better at it. And so you have a lot of the smaller hospitals in the current fee-for-service model trying to do cardiac catheterizations and a lot of procedures, whereas once this gets up and going, it would be able for a remote operator to do the procedures that need to be done and maybe deliver better outcomes than somebody who's doing less volume actually doing it standing there at the bedside. And I can imagine there's going to be a lot of pushback on this. But in most technologies, the legacy players aren't the ones who do the innovations. How do we do this in healthcare, and how do we as physicians keep from becoming irrelevant as you move into this?
I think it's a really, really insightful question. And, my whole perspective on this is we all, I think, are of a certain vintage where we were definitively trained in probably like late 20th century or very, very early 21st century medicine. And I think that if you look at and think about the same analogy of 19th century medicine to 20th century medicine, a lot changes in just a century. And from my perspective, what we need to do is not try and find ways to stop the innovation. We need to adopt it and control the innovation. I've always been one to say part of why I got into creating these digital tools was I'm not content with, and nor should I think anyone in the medical field be content with being handed something by someone else who doesn't know the context. I want to drive the bus, and I think we all should too. And I think these technologies, they're my hope and my goal, and I think many technologists kind of in the healthcare field, I think, share similar things, certainly informaticists. Our goal is not to replace physicians. The goal is to augment the physician, and because that's going to be the standard of care. But at the end of the day, until things drastically change, and maybe they do, you never say never, I think that a physician has to be in the middle, and that's going to be the standard of care because people expect that. People want that. There's a very, very common kind of theorem in informatics, which is computer plus clinician is greater than clinician alone. And I think the updated version of that for the 21st century is these emerging technologies. And XR, of course, I'm biased. That's one. But there are others, as you've called out. So generative AI, quantum computing. There are going to be these things that just fundamentally change society and medicine. And if we don't react, someone else will. So I think we need to. We need to own the narrative. There's a reason why we don't use leeches for everything anymore.
Yeah, I'm hearing you speak, and I just for so many of us in medicine, we've seen like a few decades of these very innovative companies with these great ideas that will help benefit doctors and patients, but they don't have a doctor. And then these people are meeting with administrators, either health system administrators or clinic administrators, who also are not doctors. And then they'll meet together and say, hey, this is going to be great for doctors and patients. And then deals are made. And then suddenly there's a presentation in a room full of doctors sitting around saying, oh, let's see what they're, oh, hey, this is going to be great for the doctor-patient relationship. And we're looking at each other saying, how is this going to help us? So I think what you're bringing here is like this doctor who is much, much more than, I mean, once you learn the pathophysiology and you've learned all, now you've taken a hobby and you're figuring out ways to extend the doctor-patient relationship.
You're totally right. I mean, I'm a palliative care physician. It's a fairly new field of medicine, all things considered. And our evidence base is emerging. So really the symptom management, which, as an early trainee in palliative care, I think we all have the worry, am I going to become an expert kind of symptom management clinician? And, it's understandable. And I think this is the case with any trainee. But really, at the end of the day, that stuff kind of happens pretty quickly. And then, it gets standardized and frankly, it gets commoditized. But the thing that really distinguishes an expert palliative care physician from anyone else, and I would say that with any expert clinician, any expert physician specifically, is the experience and the time and just living in that field. And actually, one of my mentors in palliative care used to say, the symptom management stuff comes and it's pretty straightforward after a while, but the psychosocial kind of complexities, that's the stuff that still is challenging to me to this day. To me, that's the opportunity, and that's what we bring to the table. And what we need to do with kind of these emerging technologies is really kind of become experts and have a seat at the table so that we can continue to be able to do kind of the other things that really define what a physician or a clinician really is. And, that's actually a nice segue into kind of, you'll see underneath my title is actually American Medical Extended Reality. What is that? So, as we started building this out for MGB, what became very apparent about a year ago is that the things that we were building at MGB actually are needed for the entire industry to support. Because to your point, what is the organization that represents kind of physicians and clinicians and the people that actually will be affected at one end of the end user? Of course, patients are the other end. And there was a white space where there wasn't an organization, there wasn't a medical society dedicated to extended reality. So that's what I founded about a year ago, the American Medical Extended Reality Association. We're a nonprofit, interdisciplinary, interprofessional medical society dedicated to advancing the science and application of MXR. We've been around for about a year. We have over 270 members. We are actually creating the very first journal with Marianne Lieber as our publisher for Medical Extended Reality, JMXR, Journal of Medical Extended Reality. Dr. Brennan Spiegel at Cedars-Sinai will be the editor-in-chief. jmxr.io is the website if you want to learn more. And we will be taking new abstracts and submissions. So we really are trying to advance the science and take ownership and have a seat at the table for what I think is going to be a fundamental technology for medicine and society in the 21st century.
Wow. There are a lot of young professionals, like medical professionals, right? Students, they're interested in this. I mean, this is a generation. I mean, they grew up with this. I look at what my 5-year-old, the technology that my 5-year-old has access to, and I hate to admit this, even my 18-month-old, the way he plays around, it's amazing, popping balloons or whatever it is. Like, if for the students who are interested in clinical informatics, and really even with what you just said with medical extended reality, what advice would you give them?
I always try to tell folks that, I've never personally kind of thought about going down a pathway because someone's told me that it's the pathway to success. I've always kind of pursued things that have been interesting to me because they're just interesting to me, regardless of whether there's a professional pathway or not. And whether that was right or wrong, whether it was because of luck or skill, it's worked out okay for me. And maybe I'm propagating big lies, but I feel like it was true to me. And I think that if you can first pursue things that are interesting to you, you're more prone to actually care and really put in the work. And then it doesn't feel like work. And then the next step is, can you convince someone else to pay you for your time? And that is a separate challenge, but also surmountable. For me, the other piece, especially when very early, folks in their career reach out, I never had a plan. Like I've always had certain directions. Like when I was a resident, I knew I wanted to do something in technology and healthcare. I actually didn't know how to do it. And I didn't even know the titles that I have now even existed, or this was a possible pathway. And in some ways, that was a little bit of just, I didn't do the diligence at the time, or I didn't even know how to do the diligence. But also it was actually helpful because it kept my options fairly open, and I was open to new opportunities. Because you never know if the next opportunity is going to ultimately be the thing that kind of defines your next 5 years, your next 10 years. I didn't know about medical extended reality 2 years ago. And now I'm the founder and president of the society. And so, like, it's surprising, right? And to me, I think that's the opportunities, and that's how I still pursue kind of things. Are, if it's not interesting to you, why do it? That's the thing. Maybe the last thing I'll say, and I give this advice to the fellows both in the palliative care program here and the clinical informatics program here. If it's not you, then who? And sometimes, like, really, the reason why a thing doesn't exist, we do a thing because of the dogma of medicine says that this is how we do the thing. It's because no one's actually thought of if it's not you, then who? So, to me, the value of actually doing a thing, even if it's not perfect, but it can be better with time, really is important, because that's how new things happen. And even if they don't work out, you gain value from the experience, right? Like a lot of the failures that I've had, and I've had many failures, nicely positioned me to do something interesting on the next thing.
Hearing you talk reminds me of a quote of Sir William Osler. And I mean, you're talking about going back a century, which a little bit more than a century, but the quote from him was, "To study the phenomenon of disease without books is to sail an uncharted sea, while to study books without patience is not to go to sea at all." And the thing I really like about what you're talking about is, it sounds to me like you're doing this really cool stuff, but you're also seeing how it's applied to patients, and you're keeping the patient at the center of things. So maybe you're the 21st century William Osler here.
Well, I'm going to take that. I'm probably going to find some way to quote you and tattoo it, and probably use that as my signature for moving forward. No, I appreciate that, Dan. But you're spot on, in the sense that I think the interesting things happen in the edges. And really, if you want to push medicine, thinking about how you find those intersections of intersections, and push on that, that's where when you're in the woods, when you're lost in the woods, that's the most exciting time, right? Because then there's not a precedent, and you can kind of chart that water and do things like create societies, and ideally, as long as, I think maybe the other piece of this, I wrestle with a lot of these, like, kind of holding two truths that are almost like kind of opposed. So uncharted waters is such a important piece, and that's incredible and fascinating. And also, I think there's this high value in just completing full thoughts. And sometimes you have to figure out ways to do both. Be in uncharted waters, yet still find ways to have full, complete thoughts that contribute back to medicine or to your profession or to whatever you're doing. And I think where I've personally been lost in the past is when I'm doing something and I'm just spiraling and I'm not completing thoughts, or I'm completing thoughts, but it's just not at the edge of something interesting, right? Like, so these are the things that I think about, and I think I would encourage kind of everyone as you kind of move down to think about, particularly in the innovation kind of digital health space.
Dr. Zhang, thank you so much. Your work really is a testament to the immense potential in medicine meets technology. I mean, really, thank you for joining us and everything that you're doing to advance medicine. How exciting.
Yeah, well, it's a pleasure. Thanks for having me. And I think that this is just an example. There's so many other folks that are doing really, really exciting things. And I just think that having platforms like this podcast and others to kind of reach people is so important, because we all only have a couple, maybe a handful, maybe a baker's dozen, if we're very lucky, years to kind of, or decades, half decades to move this forward. And then the next generation kind of pushes the wheel. So how do we continue to push? And what is that? What does that look like? And I hope that some of the work we're doing with AMXRA and also our digital innovation work at MGB inspires folks and helps push the wheel forward.
What are your thoughts on XR Unveiled? Innovation on the edges of healthcare. You've heard ours. Now we want to hear yours. And don't forget to mark your calendars, because we're bringing the conversation to you live and direct.
Join us at the highly anticipated Primary Care 24 event on Wednesday, May 22nd, where we'll be hosting a special live recording of our podcast.
It's going to be an absolute blast, filled with insightful discussions and special guests.
Whether you're a healthcare professional, a policy wonk, or just someone who cares about the future of primary care, this event is for you.
So grab your headphones, your favorite beverage, and head over to primarycareforamerica.org/primarycare24, or just click on the link in the show notes to register for the event.
Don't miss out on this unique opportunity to be part of the conversation shaping the future of healthcare. See you there.
Register now at primarycareforamerica.org/primarycare24. Faisel and I can't wait to see you there.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.